Hello again. Happy Sunday and welcome to week, I don't know, 6, something like that. Um, what we'll be talking about tonight is mood disorders, primarily depression, bipolar disorder, but also some of the other mood disorders. We'll talk a little bit about what some of those disorders look like. I will post quite a bit of sort of extra content on YouTube, links for you all to check out. I do think, in particular for this course, some of the things that I'll put out there for you to watch are every bit as useful as sitting here and listening to me. So I will maybe try to keep it a little bit shorter tonight and put more content like that out. I do think it's really useful. Just in terms of a couple of housekeeping things, I have the exam out there. So if you're having any trouble with that, please reach out and let me know. Looks like I've had quite a few of you who've submitted that already, and I appreciate that. And the grades should be on there. And if you aren't seeing those, let me know. If you just have any other questions. This week's assignment, I'm thinking of doing something a little different, and I'll put some instructions out. One of the things that we talk about throughout this course is ways that we assess for different disorders. And depression has some, mood disorders in general kind of have some unique ways of assessing that are a little more tangible than some of the other disorders. So what I'm thinking is I'm going to put a copy of a depression inventory up and give it to you all to take and have a kind of a short assignment based on that. The reason I do that is twofold. I think it's important to see what these assessments look like because they are pretty commonplace for therapists, but I also think it's good for you to see the different signs and symptoms of depression and how it relates to you. Also, I'm going to make a note to put up sort of a resource section. If you are answering some of these questions and become a little concerned or feel that you might be struggling with depression, then you are certainly not alone, and I will try to put together some resources for you to look into if you choose. You could always reach out to me. I've had many people over the years who've reached out to me and have said, as we're talking about this subject, particularly this one that we're talking about tonight, I feel it relates to me in a way that is concerning, and I can certainly point you in the direction to talk to somebody. There's no shame in that, certainly. I think if you remember back, 1 in 4 people struggle with mental illness throughout their lifetime, and probably more. And the majority of those are going to be anxiety or going to be depression. And certainly in times like this. I think we've touched on this a little bit in some of the discussion board topics because anxiety and depression run so closely together. But there's a lot of this out there now. I was talking to a friend about this very thing, just jumping ahead a little bit, when you're talking about how to deal with depression, how to improve your mood, there's a lot of encouragement to do more activities. So if you are feeling isolated and you're feeling like you just want to stay in bed all day, I as a therapist would encourage you to kind of get up and stay active. In the world we're living in right this minute, we're kind of discouraging such things, right? I was actually having a conversation with my fiance about this very thing today. Like, a lot of the sort of stress outlets that we've had over the years are now gone, at least temporarily. It's all of the distraction. Distraction is a huge part of treating depression, just trying to take your mind off of it. It becomes this vicious cycle where it's all you can think about. And a lot of the treatments that we talk about are distracting. And so we've taken away a lot of the things that we can do to distract ourselves from how we're feeling and try to improve our mood. And so as a result, I think a lot of us are feeling a little bit more down or a little bit more depressed than normal. And I think that is kind of normal right now. So we're going to talk a little bit about, I'll post more about the assignment and what we're looking for. I'll post quite a few resource links and post some videos on YouTube. So I'm going to give you a lot this week that I think will be helpful. A couple of them are going to be, I'll tag a couple of things that might be optional for you that some of you may want to spend some more time with, because I have some kind of more lengthy things that I think are very interesting, but I won't assign them just because of the huge time commitment it is to spend an hour and a half watching something. But for those of you who are particularly interested or who may be struggling with some of these issues, might be something to spend some more time in. I certainly think it's worthwhile. And if you're ever going to spend any extra time on any of the sections that we're talking about, this would probably be the one that would benefit you the most. So what we're going to go through tonight, we're going to talk about mood disorders in general. We're going to talk, first of all, about the basic building blocks of mood disorders. Like anxiety disorders have a building block of panic attacks. And for mood disorders, they take the shape of either depressive episodes, we'll talk more about that, or manic episodes. And so we'll go through those and talk about some of the specific depressive and bipolar disorders. Talk about some of the causes of those disorders, which are the same pretty much as every week. But we'll talk about some in particular and some of the treatments. I am going to, the PowerPoints for tonight will be, it's pretty lengthy. There's like I'll tell you exactly, there's 63 slides. I'm not going to go through them all for this. And just a note, I think, like I did last time, I will probably cut this in half and post 2 separate videos. So just FYI. So we'll look at sort of understanding mood disorders, how common they are, and just what these look like. So some of the things we'll talk about, I mentioned major depressive episodes, persistent depression, and I'll use some wrong terminology here. The DSM-5 deviated a lot from the DSM-4 in talking about mood disorders and changed some of the diagnostic terms, and so I will try not to use the old terms, so we'll point them out. But persistent depression is one that we have formerly called dysthymic disorders, and so I will try not to say that. And then manic and hypomanic episodes. So we'll talk some about those. Also, some of the new things like premenstrual dysphoric disorder and disruptive mood dysregulation disorder. Try saying that like 10 times really fast. Disruptive mood dysregulation disorder. I can't say it twice very fast. So we'll start out the discussion with bipolar disorders, which unipolar depression is essentially just depression. So what we call major depressive disorder formerly was called unipolar depression, as opposed to bipolar disorder, which includes depression and manic or hypomanic episodes. And so we'll talk sort of about this. Actually, we'll talk first about sort of the major depressive disorder, since depression is part of that, and then we'll come back to it. Major depressive episodes, which are building blocks to a major depressive disorder. So you have to have an episode in order to have a disorder, right? One or more episodes equal a major depressive disorder. You have extremely depressed mood and or loss of pleasure. Most of the day, nearly every day for at least 2 weeks. So when we're talking about disorders, we're talking about periods of time. So with major depressive disorder, it's happening, these feelings of sadness, depressed mood, loss of pleasure are happening most of the time in your life for a period of 2 weeks. And also you have some physical and cognitive symptoms. such as feelings of worthlessness or guilt, fatigue. A lot of people report they're really tired, just kind of chronically exhausted when they're dealing with depression. Appetite change. One of the hallmarks is gaining or losing a significant amount of weight in a short time period. Feeling restless or slowed down, and also trouble sleeping in either direction. Either sleeping too much or not being able to sleep, or some combination of the two. A lot of times people who have depression will report trouble going to sleep, too much on their mind, racing thoughts. But then this unwillingness or feeling like they can't possibly get out of bed. So that too. So when we're talking about these things, the signs and symptoms of depression, all of those things kind of come into play. My neighbor's deciding to mow the yard at just this moment, so I'm going to get up and shut this door so we can hear. All right. So the symptoms in the DSM of major depressive episode, again, this is most of the day, nearly every day for a period of 2 weeks. We have depressed mood, which in kids may look like irritability. Children, adolescents look different, look more anxious or grouchy or irritable when they're struggling with depression. Diminished pleasure in things, diminished interest or pleasure in most daily activities. Significant weight loss when not dieting, weight gain, or significant decreases in appetite, or increase in appetite. Insomnia or hypersomnia. Psychomotor agitation or retardation, meaning you are either very fidgety, restless, or you don't want to do anything at all. Feeling tired, loss of energy, feelings of worthlessness and guilt. Trouble thinking, concentrating, making decisions, recurrent thoughts of death, suicidal thoughts, or maybe even a suicide attempt. And all these are clinically significant and cause impairment. They get in the way. They're causing you to miss work. They're causing you to have trouble with family. They are significantly changing your lifestyle. And they're not because you're drinking or using drugs. Alcohol is a depressant. And can contribute to depression, or certain medical conditions can cause some depression, like thyroid conditions or heart disease. And so these are not depressive episodes strictly linked to health concerns, but health concerns may certainly feed depression. And then, so we have the depressive episodes, which are one of the building blocks for mood disorders. And then the second building block is the manic episodes. This is elevated or expansive mood for 1 week, inflated self-esteem, decreased need for sleep, excessive talkativeness, flight of ideas, thoughts that are racing, easily distracted, feeling like you have a motor. You're constantly feeling an urge to move. You're agitated. Excessive involvement in pleasurable but risky behavior. So what does this look like? Just take it from the beginning. Inflated self-esteem people have this elevated sense of their own ability or skill. They think they are super creative or can't be wrong, can't possibly be mistaken. Just they have this inaccurate sense of who they are. Feel like they can stay up for days without the need for sleep. And unlike you or I, who may have periods of time where we can stay up for long periods of time, or not sleeping or having insomnia, they don't feel the tiredness that we would feel if we stayed up for 2 or 3 days. There really is a decreased need for sleep, and it looks completely different. Often when people who are manic are talking, it sounds pressured. It sounds almost as if they're struggling to get out the thoughts fast enough. The speech is rapid. It's sometimes hard to follow. They may jump from one topic to another. It's very difficult to keep up. They may jump from one task to another. They may start building a fence, and then they go to get some paint. And while they're going to get paint, they kind of find something else to get into and start with that. And then, so there may be a lot of unfinished things that go on. They engage in a lot of risky behavior. Drug abuse is very comorbid or co-occurring with both depression and bipolar disorder or mania. And it's understandable why. People engage in things that make them want to feel good when they're manic, and don't use great decision making. Often this is things like gambling, we said drug abuse, just indiscriminate sexual activity, driving too fast, committing crimes just for the thrill, just doing anything to kind of get jumping out of airplanes and skydiving, things like that. Just anything to get a thrill. The trouble is this is impairing to their everyday functioning. It causes problems. Now, it is true, a lot of, we've talked about this a little bit on the discussion board, a lot of artists and musicians have bipolar disorder, and they talk about how they feel when they're manic and how it enhances their creativity, and there is some truth to that. But there's also some truth to the idea that they have a hard time regulating. So they may get some really creative things that happen then, but there could also be a lot of just garbage or also self-destructive behavior that go along with that. We've talked a whole lot about Kanye West recently, and I think that's just because he's in the forefront right now. He's on TV all the time, and he's sort of very visibly dealing with bipolar disorder right in front of our eyes. There's been some things this week regarding him on Twitter. He got banned from Twitter for posting pictures of some of his contracts and urinating on a Grammy, and his wife has come out and said that I don't think she came out and said, I think it was leaked, but that she kind of had enough. So this is, when you're someone of his stature, you may feel like you have that sort of power, but you could face losing millions of dollars. One of those recording contracts that he showed, like the minimum was $800,000 a year, which is like an obscene amount of money to us, probably not to him. But the maximum's like, several million dollars. So you could reasonably lose quite a lot of money just for this sudden urge to kind of engage in this sort of behavior. Again, that goes back to the inflated sense of self-esteem. His value, his inherent value, is more significant than what other people may see it as being. And so, unfortunately, I think we're seeing this in real life right now. And a few years ago, we lived through it with Charlie Sheen, and we've seen Demi Lovato and some other celebrities kind of live their mania. Britney Spears a few years ago, another example. So you see this, and it's very hard to watch. You can flip through there, and you can see the DSM criteria, flip through the PowerPoints. Now, there's sort of a lesser version of these. I talked about depressive episodes and manic episodes. There are also hypomanic episodes, which are a little shorter in duration. They last at least 4 days, but not a week. They're less severe. They have fewer and more mild symptoms and less risky behavior. So the increased creativity, the running motor, the not need for sleep, but they're not engaging in things that are going to get them arrested or get them in trouble with their workplace. It can be problematic still, because remember, it has to be problematic to be a disorder, but it's less so than an actual manic episode. And then oftentimes you have these mixed features where you have some depressive episodes mixed with some manic episodes, mixed with some anxiety. So you have a lot of different things here. So major depressive disorder is one or more major depressive episodes, and it's separated usually by a period of remission. People don't stay chronically depressed all the time. Well, some do. But with major depressive episode or disorder, people don't stay depressed 100% of the time. They have periods of depression, followed by periods of feeling better, followed by periods of depression. Single episodes are possible, but very rare. Most people who have an episode of depression are going to have a second, sometimes a third. Usually it's something you're going to deal with throughout your life. Most people have dealt with depression. Most people have dealt with clinically significant depression and could be diagnosed. Most people don't ever go to treatment for that. Stigma, feeling that you can get through it on your own. Also, just when you're feeling depressed, you don't really feel like going out and going to treatment. You don't care about feeling better. You just kind of ride it out and try to get through it. So different people respond differently to that, but it's very, very common. And we talk about sadness versus depression the first week or so. And it's completely normal to be sad. For instance, after the death of a loved one or breakup, it's absolutely okay to be sad, and you don't need to feel like you need to go to a doctor or get on some medicine or therapy or anything like that. If this goes on for a long period of time and the sadness becomes overwhelming, it becomes to a point where you don't want to get out of bed and you don't want to do anything, then you're dealing with something a little more significant, and then you need to consider seeking treatment. Grief is the same way. Until the DSM-5, we cannot diagnose depression as a result of grief, and now there's this understanding that grief that goes on past sort of a normal period of grieving can be clinically significant. It can start a major depressive episode, lead to a major depressive disorder. So grief is, now we kind of realize that grief does play a role, but it's completely normal to grieve. But if it goes on for weeks and months, longer than you would think, and you're having trouble getting on with your everyday life, not to say that you're always going to feel great after you have a loved one pass away, but if your functioning level is impaired, then it becomes something different altogether. It's a depressive episode that just has this grief component. And it makes it a little different to treat, sure enough. But that was the start. So I mentioned, major depressive disorder tends to have these episodes followed by feeling okay, followed by other episodes. But there is a depression that is just sort of similar to generalized anxiety disorder. Always this low level of anxiety, remember, that persists usually throughout life. In depression, this is persistent depressive episode, formerly known as dysthymic disorder, or dysthymia. And this is at least 2 years of depressive episodes, or depressive symptoms. Not as severe symptoms as you usually get with major depressive disorder, but this sort of chronic feeling of sadness, of feeling overwhelmed, of feeling fatigue, of feeling like life is just too much, right? But it's on a lower level and less intense, but more constant. And in order to meet this, you have to have 2 years of depressive symptoms, depressed mood most of the day, at least half the days, and no more than 2 months symptom-free. So it has to really be ongoing, and symptoms persist over long periods of time, usually, often 20 years, 30 years, or a lifetime. And you may have more severe periods in here that where you will actually meet criteria for a major depressive episode or disorder. So there can be more severe periods of time, but in general, it's just this sort of low-grade, constant feeling of being depressed. And that can be pretty debilitating. Like generalized anxiety disorder, it takes a toll on the body. You have a lot of physical complaints. You have headaches. You feel lethargic. Your stomach hurts. Your back hurts. So people have a lot of physical complaints as a result of persistent depression. Also, your suicide rates are higher, and that is certainly something to be concerned about. One of the newer depressive disorders is premenstrual dysphoric disorder, and this is depressive symptoms that occur prior to the menstrual cycle beginning in women and leads to distress and impairment. And this is more significant than your typical symptoms that you would experience. This is enough to cause clinically significant, distressful, depressive type symptoms. And it was pretty controversial, I'll say. There was a lot of discussion about whether it would be included, whether or not it meets the criteria for a real psychological disorder, and in the end, it was decided that it does. There is enough of a evidence base that would suggest that there are certain women who have really serious depressive episodes as a result of their menstrual cycle, and it warranted consideration for a disorder. And with this, you have to have 5 symptoms present in the final week before the onset, and it improves several days after. And we're talking about mood swings, irritability and anger, depressed mood, anxiety and tension. Also, the other symptoms of depressive disorder, lack of interest in things that you used to be interested in, trouble concentrating, lethargy, that sort of thing. So again, it was relatively controversial, but it is there, and I think over time, as we have in the few years since this was originally put out there, you can certainly see more and more people seeking treatment for it. So it certainly seems to support the idea that there is something there and it isn't just this make-believe disorder. And I am going to, let's see, I'll talk about bipolar disorder a little bit, and then we'll cut this video off and start the second one. Bipolar disorder is, again, I mentioned earlier, unipolar depression, just one pole. And bipolar disorder is characterized by dual symptoms of depressive episodes and manic episodes. The average age of onset is 15 to 18 years old, so it's something that generally starts to affect young adults, can begin earlier, and it's generally chronic in nature. Suicide is a high risk factor for people experiencing this, and like we talked about before, there's sort of a lesser version of this. Bipolar 2 disorder is this alternating between major depressive disorder and hypomanic symptoms. So again, not quite as many symptoms or as severe symptoms of mania or is compared to mania. And the average onset there is a little older, and it also tends to be chronic, and a lot of those people who are diagnosed with bipolar 2 go on to eventually meet criteria for bipolar 1. So, an easy way to remember it: if you have a manic episode, always bipolar 1. If you have hypomanic episodes, but never a manic episode, bipolar 2. But even one manic episode makes it bipolar 1 disorder. And then we have, cyclothymic disorder, which is sort of like, I'll post a video of Stephen Fry, who's a comedian, British comedian, who refers to cyclothymic disorder as bipolar light. And that is sort of true. It's like the dysthymic disorder, persistent depression. It's this lower grade version of bipolar disorder that is more chronic in nature. Symptoms tend to last longer, but be a little less severe. So you alternate between the periods of mild depression and mild hypomanic symptoms, but you don't meet criteria for a full depressive episode or a full manic episode. And it tends to stay around for a longer period of time. And in order to meet this criteria, we're talking about 2 years of symptoms. Again, like persistent depression, this is sort of persistent mood cycling or mood swinging. And the average age of onset here is 12 to 14 years, so it starts relatively young. More common among females, and again, a third of those go on to develop bipolar disorder and meet criteria. So relatively common. And this would be a good place to talk about some of the videos I'm going to post. I'm going to post the video of Stephen Fry. I'm going to post 2 versions of that. One that's really like an hour and a half. I think it's really, really worth watching. And I would strongly encourage you to do that. And then I'm going to post a shorter version. The longer version will be optional. And then the shorter version I'll post that I want everybody to watch. I just think his discussion is very frank about his struggle with bipolar disorder, and very interesting. He's very intelligent, so there's a lot of insight into it, and it's easier to hear it from someone who's experiencing it than it is to hear me talk about it. I'm going to post some videos on assessing, treating people with depression and bipolar disorders, and something else that I can't remember right now, but I'll post more about that later. So in terms of prevalence, we talk about how often these things occur. Worldwide lifetime prevalence for major depressive disorder is 16%. That is so low. And I think realistically that's probably higher. That's a function of most people not seeking treatment for depression. About 6% have had major depression in the last year. Again, that's really low. Women are more likely to have a major depressive episode than men. Women are also more likely to seek treatment than men. So again, it's probably underrepresented in men. And bipolar disorder tends to affect people equally. And I'll tell you, in general, why is because people tend to get in treatment for bipolar disorder because they get in some kind of trouble. They get in legal trouble. They've engaged in some kind of risky behavior that's led them to being required to get into treatment. Either they're hospitalized or put in jail or end up with some consequences that push them towards treatment. Largely, people with depression are pursuing that on their own. So you get a more true indication of the breakdown. And so it comes out that men and women are generally affected equal. I think it's probably closer than it actually looks in depression, just because men are less likely to seek treatment unless they're forced to. Adults over 65 have about 50% less diagnoses of mood disorder than the regular population, the general population. And there seems to be a prevalence of depression across cultures. So no matter the cultural breakdown, you do tend to see these same symptoms that come up again and again. I'm going to go ahead and stop this video here. It's getting around 35 minutes, and then I will start the second one shortly. So see you in seconds.